Hello, my name is Mark Roberts. I'm a medical consultant working in Craigavon Area Hospital in the acute medical unit. I'd like to talk to you about a quality improvement project that I'm involved in our unit designed to help improve the care of frail older people. So it's useful to set the overall context. The potential problems that many frail older patients have when they're hospitalised is that there can often be delays in addressing issues such as confusion, whether that is a long-standing matter or a new problem related to their acute illness. There can be delays in addressing their mobility needs and maybe delays in getting patients mobilised, which causes difficulties such as bed pressures and infections. There can be too many or there may be inappropriate medications, particularly in the tablets that patients are prescribed. There can be invasive equipment such as catheters that are not required any longer or may not be required in the first instance. And also for a small group of patients, that we can sometimes fail to forward plan in case people aren't responding to the measures that we're taking to try and improve their health, and therefore we need to concentrate more on their quality of life and their end-of-life care. So as part of a response to these issues, we've been involved in a national quality improvement project called Frailsafe, which is really a safety checklist for older people entering acute hospital care. It has used a group of experts to determine what the highest impact evidence-based interventions that are out there that may be able to be actioned on and reduce harm. And the checklist, which you can see on the right side of the screen, is designed to prompt a focused interaction between members of the clinical team. Healthcare is a very complicated business. There are lots of different variables, and the point of the checklist isn't to try and dictate care, but just merely to act as a prompt in the same way that a pilot starting a flight path would have various prompts about safety critical processes. And we're trying to mirror that in our healthcare setting for this group of patients. So I think it's reasonable to remind us all that good care isn't rocket science. It is about connecting what we know with what we do. And that's just a light-hearted reference to that, and that we need to continuously be aiming to improve the connection between those two things. So we can go back to the original premise, which is about a focus on reducing harm. And the main areas have been highlighted on this slide. They include reducing tablet burden, thinking about the number of tablets people are on, thinking about the side effects they may be having, both directly and after interacting with each other. Determining what we would call appropriate ceilings of care. So patients may require next steps such as major surgery, or they may need intensive care treatment where machines help assist their breathing, or it may be that they would not be fit and likely to benefit from such procedures, and we need to recognise that earlier and be frank and honest both with the patient and their next of kin in regards to the limits and potential benefits of treatment. We should also be thinking about reviewing things such as urinary catheters, tubes that go into the bladder to drain the bladder, intravenous lines such as lines going into the veins to help administer medicines. Often we leave these types of equipment in for longer than is always required, and reducing the dependence on those reduces the complications from these invasive equipments, such as infections or a loss of dignity or problems with mobility, for example. A big area is recognising what we call delirium, which is really about acute confusion, and by recognising it we can treat it earlier, and earlier treatment is generally regarded to be more successful and less burdensome for the patient and the family. And finally, an important aspect of hospital care is thinking about making sure that bed moves are in the patient's best interests, and that particularly for this vulnerable group of patients, we're not inflicting multiple bed moves across the hospital and eroding the continuity of care that they've been receiving, and therefore creating difficulties with communication or expectation, or in terms of following through a previously agreed management plan. And all of these factors are really designed to improve the quality of life. So, like all quality improvement projects, we should really start with the why, and the why is to improve quality of life for a very vulnerable group of patients. We started early with getting a small group together to meet regularly, to establish a focus, to try and roll out some of the principles to our team in our 35-bedded unit. And we really wanted to start small and scale up gradually, and accept that and when you're learning to implement a new measure, you can't expect instant success, because that is not how the real world is. And we need to try and gradually build up and incrementally make gains. And the graph in the lower part is just a small visual representation of some of the variation that we had. Some weeks we were doing better than others, and the idea is that we continuously try and learn from the strengths and weaknesses and make the subsequent weeks better. So at this stage, a reasonable question to ask is, anything changed since we've been implementing this? On the left side of the graph, you can see a graph showing for the patients that we were using the checklist for. Initially, we were often quite poor at documenting whether we'd considered next steps if a patient worsened, and whether we communicated these to the patient and the family. And initially, you can see often we were quite poor. In fact, one week we hardly addressed that at all, or it seemed on the notes. But we've become consistently much better at doing that, and I think that's a good mark of quality. So on the right side of the graph, you can see some overall data trends which may not be directly related to the Frailsafe project, but we are confident the Frailsafe project has contributed to it, because this is a graph particularly about older patients, and we think this quality improvement project has helped us achieve a greater number of safe and effective discharges for that age group directly from the acute medic unit, and a reduced dependence on transferring patients out to other wards, and hopefully therefore improving continuity of care. And in particular, in the lower part of that box, you can see of the patients that we tracked, and there were many more than 180 but that were subjected to this checklist and the benefits of it. But of the 180 that we tracked, we found that over 50% of them were sent home directly from the acute medic unit, and of the vast majority of the other patients who were moved to other wards for medical reasons, they had no further moves. And I think that will have enhanced their quality of care and their experience. So this is a continuous improvement project. It has never really achieves its endpoint. It's always trying to move to the next step of improving matters, and we're trying to link the Frailsafe principles into a regional delirium pathway, which are being rolled out across Northern Ireland to detect early confusion associated with hospital-related illnesses earlier. And we also wanting to widen the Frailsafe principles that are initially intended for a frail older group of patients to also certain younger groups of patients who may have similar vulnerabilities, to make sure that everybody who can benefit from this holistic multidisciplinary approach can do so. So in summary, there are opportunities to improve the quality of life and reduce the harm for some of the most dependent and vulnerable members of our society. We see the Frailsafe checklist as an important prompt, a tailored prompt that can help us achieve that. I'd like to pay particular thanks to the multidisciplinary team in the acute medical unit for supporting this project and continuing to embed it, and also the National Frailsafe Quality Improvement Project group, which is across several sites throughout the UK National Health Service. And if anybody would like some more information on that, they can check out their website on frailsafe.org.uk. Thank you.